Last month, the scientific world commemorated the 140 years passing of Gregor Mendel. Gregor Mendel is the father of the science of inheritance and subsequently of genetics. He is an Austrian friar who, in his monastery, he grew peas and he looked at different characteristics, specifically seven characteristics of peas. If they are small, the stalk is tall or short, and the peas, if they are wrinkled or smooth, and if the flower is white or purple. So he cultivated that, thousands and thousands of them over the years, and he wrote them, and that was the basis of the inheritance. So I thought that in our field, in the field of pain management, what are the roles of inheritance and genetics in pain? So before we elaborate further, I believe it is important to differentiate between what is sex and what is gender. Sex means real sex, meaning that a person with male reproductive system or female reproductive system. Gender is so it is really anatomical and of course physiological. The gender is the perception of a person. We do know that some people, even though they are male as far as the reproductive system is, but they act and they feel like female. So we have to differentiate that in our study. So the question is, there is really difference in the pain perception between the two sexes, and in what cases of pain, and what are the clinical implication of that difference. That is the topic I want to address today. So they are practically all the animal studies were done historically on male animals, laboratory animals. And they discovered later on from observation and from scientific findings that there are really difference between the two sexes. And we are going to talk about only the human part of the human aspect of pain perception, and their implication. In the difference is it is striking in many fields, perhaps not as much as in pain perception and its management, but so much so that the National Institute of Health in 1994, they said that as a prerequisite to fund any research, there should be representation in the research study of both sexes. Well understood. In brief, we found out that females are more sensitive to pain, and in fact, many of the painful conditions are a lot more common in female than in male, and I'm going to list them now. First, the headache. We do know that 1 out of 7 females, they do have migraine headache, and also the tension type headache, the post-dural puncture headache, the cervicogenic headache. We deal with that in pain management quite a bit. Meaning, cervicogenic means that headache that originates from the cervical spine, and we treat it with medial branch block and RFL. On the other side, as far as headache is concerned, cluster headache is by far a lot more common in male. Now, after the headache, as far as the mouth, we know that there is temporomandibular disorder is a lot more common in female. Trigeminal neuralgia also more common in female. As far as autoimmune disease, for example, rheumatoid arthritis, systemic lupus erythematosus, and scleroderma, they are all more common in female. And we are going to elaborate on what is possibly the reason for that predominance in female. In extremities, the upper extremity, the carpal tunnel syndrome, the CRPS type 1, they used to call it RSD, the venous insufficiency, Raynaud's phenomena, in the lower extremity, piriformis syndrome, also Raynaud's, and of course the pelvic pain is a lot more common in female than in male, although it does exist in men also. It's not really the exclusive domain of women. The irritable bowel syndrome, it is more common in female. Rare condition called proctalgia fugax, meaning that there is a significant spasm in the anus and the rectum, is more common in lady. So now the question is, what is the mechanism of that predominance in female in those conditions? The short answer is we do not know for sure. However, there are quite few theories that were advanced to explain that. Number one, the genetics. And when we talk about genetics, we go far beyond the XX chromosome of the female versus the XY chromosome of the men. There is hormonal, and the hormones, they play significant role in the perception of pain. For example, the temporomandibular disorder, it happens only after puberty. Migraine, to a large extent, happens after puberty. So there must be association between the sex hormones and those painful disease. There are also during the menstrual cycle, the perception of pain is varies, especially in the follicular and during the menses. The perception of pain is more than in other phases of the menstrual cycle. There is issue of psychological issues, of course, which by themselves could be influenced by genetics. There is the cultural issue. So there are, these can widely explain the difference. So what specifically is different between female and male? Number one, the threshold of pain is lower in female. What I mean by that is that if I'm going to press my my hand, in male you have to press really hard for them to report pain. In female, you don't need to press that hard. Small pressure, lesser pressure, I should say, will elucidate pain. And then the amount of pain that is reported varies. In the female, they report high intensity. If a man report, let's say X over 10 pain, in the lady they report X plus something over 10, meaning they press more. and they tolerate the pain less effectively than men. Means that they have lower tolerance to pain than the male counterpart, and it persists with them further. So those are the practical differences in pain management that we have to be alert to them and take them in consideration. However, I must conclude that only in the third of the study did show that there is difference in perception of pain between men and female. It is not universal findings by any means, and furthermore, the amount of the difference, the confidence interval is wide, meaning that they can be that it is not for sure that we are talking about significant difference, but however there is difference and we have to manage it. So now, what is a clinical implication? It seems that the female, they have more resistance to morphine, the mu receptors, part of the narcotics that they work on the mu receptors, they don't work as well in female than in male. However, the female, any medication that works on the kappa opiate receptors, like nalbuphine, like buterphanol, they work better in female than in men. So in conclusion, we must be cognizant in our field, the field of pain management, that there are differences about in the pain perception, the intensity of the pain, and the tolerance of the pain between the two sexes. We noted here that the majority of the condition that the pain is felt more intensely in female is when there is sensitivity of the pain, meaning wind-up phenomena. We do know that in the pain management field, if somebody feels pain, the body does not become used to that. It becomes lesser tolerant to that. For example, we do know the migraine headache, all the autoimmune, we mentioned the rheumatoid arthritis, the pelvic pain, anything that is chronic and perpetuated, it is more common in female. The treating physician should be cognizant of this fact and tailor and be flexible in his treatment when it comes to approaching that in the two sexes. Thank you so much.